Thank you for viewing this educational program. This module will discuss rectal bleeding and proctitis, which can occur following prostate cancer treatment with radiotherapy. The treatments for prostate cancer are usually very well tolerated. This module will outline some of the rectal symptoms which can occur after radiation therapy for prostate cancer. Specifically, we will discuss rectal bleeding and proctitis, which is inflammation of the rectum. This module will explore how these symptoms can be caused by radiation therapy, and some of the tests and treatments that a physician may recommend should these complications occur. Radiation proctitis is the medical term used to refer to inflammation of the rectum caused by radiation damage. Proctitis can be accompanied by symptoms like diarrhea, mucus discharge, and rectal urgency, which is the inability to delay a bowel movement. Some of these symptoms are caused by direct irritation to the rectal surface from radiation. The management of bowel habit changes is discussed in a module entitled Bowel Habit Changes Following Radiation Therapy for Prostate Cancer. Proctitis can also be accompanied by tenesmus, which is the persistent feeling of a need to pass stool, and by hematochezia, the medical term for blood passed with the stool. Tenesmus refers to the sensation of needing to pass stool, even when none is present within the rectum. Radiation can affect the nerves and muscles responsible for contraction of the pelvic floor and the anal sphincters or valve muscles. These structures are involved with properly coordinated bowel movements. Damage to these structures, or direct irritation from radiation, can lead to improper signaling that stool is present, causing tenesmus or rectal urgency. Although they are different symptoms, the sensation of tenesmus can be powerful and can cause rectal urgency. Hematochezia is the passage of bright red blood from the rectum. Although the majority of patients who are treated with radiation for prostate cancer will never develop significant symptoms, a small proportion can have persistent hematochezia. A proposed mechanism for the development of bleeding is that radiation causes damage to small blood vessels within the rectum. Tissues in the surrounding bowel then experience a reduced blood supply, and the affected bowel can develop fibrosis or scar tissue. The affected tissue attempts to grow new blood vessels in response to the damage and reduced blood flow. However, these newer vessels are fragile and less organized than the original blood vessels. The medical term for these small vessels is telangiectasia. These fragile new blood vessels bleed easily when subjected to trauma from passing stool. Hence, bleeding is a commonly reported symptom in patients with proctitis. Proctitis is uncommon after prostatectomy. Following radiation, however, short-term or acute irritation of the rectum is possible. 10 to 30% of patients receiving radiation therapy to the prostate and seminal vesicles can experience diarrhea or loose stools. The diarrhea is typically mild, although less than 1% of patients can experience severe diarrhea, which is defined as more than 10 bowel movements per day. Other symptoms such as rectal urgency, mucus discharge, rectal leakage, and rectal bleeding are also possible, but are less common, occurring in 5 to 10% of patients. After high-dose rate brachytherapy or external beam radiation treatment, acute rectal symptoms generally resolve 6 to 8 weeks after the treatment is complete. Symptoms from low-dose rate seed brachytherapy can take up to 1 year to resolve, as the radioactive seeds give off radiation over a number of months. Long-term or chronic side effects are defined as symptoms which either appear, worsen, or persist more than 6 months after treatment. These can occur in 20 to 50% of patients, and are usually mild in nature. Some examples of these include mild diarrhea, slight rectal discharge, or bleeding. Mild symptoms generally do not significantly impact day-to-day quality of life or habits. Because the radiation from low-dose rate seed brachytherapy is delivered over a long period of time, it can sometimes be difficult to distinguish temporary acute irritation of the bowels from chronic changes brought about by treatment within the first year. Many patients will have an improvement in their symptoms during this time. Changes to bowel habits significant enough to affect quality of life are an uncommon but possible complication following radiation treatment. Changes like rectal urgency or discharge, significant diarrhea, or pain can sometimes be significant enough to require changes in lifestyle or prescription medications for treatment. A more detailed discussion about bowel habit changes after radiation therapy is available in a separate module. Bright red blood passed from the rectum can occur in 10 to 30% of patients following radiotherapy. It is usually mild and does not require additional intervention. In rare cases, making up 1 to 2% of patients, this bleeding can be significant enough to require interventions like blood transfusions. External beam radiation therapy can sometimes be directed at the pelvic lymph nodes near the prostate. When treatment includes the pelvic lymph nodes, this increases the risk of gastrointestinal side effects because more bowel is exposed to the larger radiation field. Compared to external radiation treatments, both low dose rate or SEED and high dose rate or catheter brachytherapy have a lower probability of causing radiation proctitis. The short-range nature of these treatments exposes less of the bowel wall to radiation. However, combination treatment, including both external radiation and brachytherapy, carries a higher risk of proctitis than either treatment alone. Patients who experience bowel habit changes following treatment for prostate cancer should mention them to a physician. An investigation into the cause of these symptoms begins with obtaining a detailed medical history. Patients might then be asked to keep a diary logging the timing and character of bowel movements, occurrences of bleeding, and associated dietary triggers. Patients could be offered a physical examination, including a digital rectal exam. If needed, patients could be sent for a sigmoidoscopy or colonoscopy, which is an examination with a camera. In order to avoid causing further irritation or damage, taking a biopsy or sample of the rectum should be avoided unless discussed with the whole medical team, including the surgeon or gastroenterologist and the oncologist. For more information, there is a separate detailed module on colonoscopy. There may be additional tests ordered, such as CT scans or blood work. A detailed description of the bleeding can often give clues about the location and cause of rectal bleeding. Some of the questions patients could be asked include: how often does the rectal bleeding occur? Does it happen with every bowel movement, or is it less frequent, for example, once a week or once per month? Recently, has this been getting any better or worse? How much blood is there? Are there just small flecks of blood, or is the bleeding more significant? This can be very difficult to estimate, especially if the blood mixes in the toilet bowl, but a rough estimate can be helpful. Where is the blood? Is it mostly on the toilet paper after wiping, or mixed in the water of the bowl? Is it coating the stool, especially the last pieces to be passed? Or is it mixed in with the inside of all of the stool? Are there any particular foods or beverages that trigger the symptoms? What is the stool like? Is it hard or very loose? And what color is it? What is the stool caliber or thickness like? Has it been very thin like a pencil or recently changed? Does the stool have any unusual smell to it? Is it greasy and does it stay floating at the top of the water? Is there any associated pain in the abdomen or pelvis? And finally, has there been any history of recent gastrointestinal illnesses or travel outside of the country? Although radiation therapy can cause complications like bleeding, it is important for a doctor to rule out other causes of rectal bleeding, as they could be more serious, easily treatable, or require different treatments. Pre-existing inflammatory bowel disease, like ulcerative colitis or Crohn's disease, increases the chance of developing rectal symptoms after radiotherapy. Occasionally, patients may not be aware that they have these conditions until after receiving radiation treatment. inflammatory bowel disease can be treated with specific medications. Hemorrhoids, which are engorged rectal veins, or fissures, which are tears in the rectal lining, are common problems affecting men. Both can cause rectal bleeding. Radiation therapy and loose bowel movements can make these worse. These can be treated with locally directed therapies. Bleeding can also be a symptom of a colorectal cancer. Although this is rare, patients who have not been previously screened for colon cancer may be at risk. Patients with radiation proctitis can often be treated initially with conservative options. Decreasing intake of insoluble fiber, or roughage, and sugar intake may reduce irritation to the bowels. Stool softeners can be helpful if constipated, and may reduce irritation or bleeding from the rectum due to direct trauma from hard stool. Patients can be prescribed specialized medications to help reduce proctitis, which in turn may reduce bleeding. Examples of medications that may be used are listed here. Sucralfate is a protective agent commonly used in the treatment of ulcers. It is applied directly to the irritated rectum. It is delivered as an enema where it coats the rectum to help heal damage to the small blood vessels. This medication often helps with bleeding, but the symptoms can sometimes reoccur after the sucralfate is stopped. Some of the side effects of this medication include nausea, dizziness, drowsiness, dry mouth, and constipation. Patients can be prescribed topical steroids, which reduce inflammation when directly applied to the rectum. They are available as a foam or as suppositories. When inserting suppositories, care should be used to prevent further irritation or trauma to the rectum. Steroid foam formulations also contain anti-itching agents for relief of generalized proctitis symptoms. Side effects of steroids can include local irritation and changes to surrounding skin. Rarely, they can increase the risk of infection or cause an allergic reaction. Metronidazole is an antibiotic that can eliminate harmful gut bacteria. It is sometimes prescribed for bowel habit changes after radiotherapy or for gut infections. 5-aminosalicylic acid, or 5-ASA, is a powerful anti-inflammatory medication also used for the treatment of inflammatory bowel diseases. It can be applied topically to the rectum to help reduce proctitis. It should not be confused with ASA, or acetylsalicylic acid, which is the generic name for aspirin. 5-ASA comes in a variety of brands and formulations, including Salofalc, Mezavant, Pentasa, and sulfasalazine. Colonoscopy can be a useful investigative tool to rule out colorectal cancers. A colonoscopy can also visualize the rectum and identify radiation damage and sources of bleeding. Depending on the findings, locally directed therapies for bleeding can also be provided at the same time. If the bleeding is caused by radiation, offending blood vessels can often be identified during endoscopy. If appropriate, treatments can be applied directly to the vessels. A chemical called formalin can be applied to the vessels, causing them to scar. Endoscopists can also use tools like argon plasma or lasers to scar and destroy the offending vessels. In Canada, the most common treatment is argon plasma coagulation, or APC. The following 3 images demonstrate radiation-induced proctitis before, during, and following argon plasma coagulation treatment. Hyperbaric oxygen can sometimes be used if conservative, more traditional measures fail. This treatment is delivered in a specialized chamber where patients breathe 100% oxygen under increased atmospheric pressure. This may improve the amount of oxygen delivered to damaged tissues, thus assisting in their repair and revitalization. Surgery can be considered for major, persistent bleeding, but it is usually reserved as a treatment of last resort. In summary, inflammation of the bowels, or radiation proctitis, is a common side effect following radiotherapy for prostate cancer. This can sometimes lead to either acute and temporary or persistent and chronic symptoms like rectal bleeding. There are a number of investigations and potential treatments for rectal bleeding following radiotherapy. Patients experiencing complications following treatment should discuss them with their doctor or medical team. Thank you again for viewing this educational program.